Welcome, and thank you for joining us for today's webinar, Vaccinating Adults with Chronic Conditions, Recommendations and Lessons Learned. My name is Kathleen Amos, and I work at the Public Health Foundation, and I'm joined by my colleague, Vanessa Lammers, and we're pleased to be hosting this webinar on behalf of the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention, or CDC. We have two excellent presenters with us for this webinar and are very much looking forward to sharing their presentations with you. It is especially important for adults with chronic conditions to be up to date on recommended vaccinations, as they are at increased risk for complications from certain vaccine-preventable diseases. Especially in these challenging times, patients rely on healthcare professionals to advise them about important measures to protect their health, and a recommendation from a healthcare professional is the strongest predictor of whether adults get vaccinated. For this webinar, we have two physicians joining us to discuss vaccine recommendations and strategies for increasing immunization rates among adults with chronic conditions such as heart disease, lung disease, and diabetes. First, we have Lieutenant Commander Atara Jalawi. Dr. Jalawi is a medical officer with the U.S. Public Health Service and the Adult Immunization Lead in the Immunization Services Division at CDC. She currently serves as a co-lead for the National Adult and Influenza Immunization Summit's Access and Provider Work Group and serves on the working group for the Advisory Committee on Immunization Practices Adult Immunization Schedule. Before joining the Immunization Services Division in 2020, she worked in the Division of Reproductive Health at CDC since 2012. Dr. Jalawi trained at Emory University in the Department of Gynecology and Obstetrics and stayed at Emory for both fellowship training and family planning and to obtain her MPH in epidemiology. She remains clinically active at Grady Memorial Hospital in Atlanta and is an adjunct faculty member at Emory University School of Medicine. And she'll be followed by Dr. Sarah Coles. Dr. Coles is an assistant professor at the University of Arizona College of Medicine, Phoenix, in the Department of Family, Community, and Preventive Medicine. She received her undergraduate degrees from the University of Arizona, attended medical school at the University of Arizona College of Medicine, Phoenix, and trained in family medicine at the Banner University Medical Center, Phoenix Family Medicine Residency. Since completing residency, she has stayed on as faculty at the Family Medicine Residency and at the medical school, where she developed the longitudinal patient care course. In addition to practicing full-spectrum primary care, she is involved in curricular development, organized medicine, community engagement and advocacy, and teaching medical students and residents in a variety of settings. She is a member of the American Academy of Family Physicians Commission on Health of the Public and Science. Thank you both for being here today. And with that, I'll turn the floor over to Dr. Jalawi to get us started.
Good afternoon. Thank you so much for having me here today and giving me the opportunity to present. Here are my disclosures. I have no disclosures, but I have listed some disclaimers for CDC presentations, particularly for vaccine-related discussions. I will not be going into detail during the presentation on unlicensed products or off-label use. For the next 20 minutes or so, I'll provide an overview of adult vaccination coverage, review adult vaccine schedule focused on adults with chronic conditions, review guidance related to immunizations during the COVID pandemic, and provide resources for healthcare professionals. I'd like to spend a good amount of time discussing adult vaccination coverage. I'll present data on coverage trends over the last decade and for vaccination decision-making. Finally, I'll review some enlightening data on why vaccines are especially important for adults with chronic conditions, which can be useful when you counsel your patients. This graph has a lot of information, so let's walk through the latest available data from the National Health Interview Survey, or NHIS. This report is available online and includes self-reported vaccine data and is nationally representative. Although the point estimates for each year between 2010 and 2017 vary by only a few percentage points, linear trend tests indicated that most vaccines did increase significantly over the 7-year period. And these increases include influenza vaccination coverage among persons aged 19 years or older, which is the purple line with squares, from the 2009 to 10 influenza season, to the 2016-17 season. Pneumococcal vaccination coverage also increased among increased risk persons aged 19 to 64 years and persons aged 65 years or older. Tdap vaccination overall among persons aged 19 years or older, Tdap vaccination among 19 to 64-year-olds, and Tdap vaccination among persons aged 65 years or older also increased. Hep A vaccination among persons 19 years or older increased. Herpes zoster vaccination of persons aged 60 years or older, and HPV vaccination of females and males aged 19 to 26 years also increased. Still, overall coverage levels remain low for all the routinely recommended vaccines for adults. These data shown here were collected as part of CDC communications planning with the public. Self-administered online market research surveys were sent to a random sample of households that returned similar surveys in the recent past during September through October 2015. Over 3,500 surveys were completed. Of the sample, 31% were not aware that they needed vaccines beyond flu, but a similar 30% say they make sure to be up to date with recommended vaccines. Of the other approximate one-third, the proportion who are aware that they need vaccines other than flu, about 21% haven't thought about getting them, haven't decided yet, or have decided but haven't taken any action. Only 7% have made decisions not to get vaccinated. These data here are striking and show many opportunities for improvement regarding Tdap, pneumococcal, and zoster vaccines. Patient awareness for needing the vaccine is an obvious area for improvement, particularly for Tdap. More than half of respondents didn't know they needed the Tdap vaccine. These percentages were lower for pneumococcal and zoster vaccines. Those percentages aware of needing any of these three vaccines but either hadn't thought about it, considered it but hadn't decided yet, or decided to do it but haven't gotten it range from 2 to 11%. Also striking is the less than adequate percentages at the bottom showing the proportion of respondents who actually got each of the three vaccines. Based on data collected during the same vaccination communication planning, it's important for you all to realize how important your support of vaccination is. A strong recommendation makes a difference. That means one coming from you when you talk with your patient. Included later in the deck is a resource which may help, a series of videos entitled How I Recommend that have tips and pointers on how to make strong vaccine recommendations to adult patients. Based on the same survey data I showed a couple slides ago, here we have the percentage of patients who reported that the following vaccines were recommended by a medical professional, with each bar representing years between 2012 and 2015. The highest percentages recalled recommendations for flu vaccine, and lowest percentages were for Tdap, followed by zoster, then pneumococcal vaccines. This all boils down to the simple truth that adults are not getting the vaccines they need and there's more work to be done. So why is this important? I'm going to discuss flu and pneumococcal infections in the next two slides to highlight some really important information you may not be aware of. Getting the flu, particularly for adults with the conditions listed on this slide, can lead to increased risk of complications. What you may not realize is that the complications are not just directly related to the flu infection. When adults with these conditions undergo the stress of a flu infection, their disease state becomes compromised. Adults with high-risk medical conditions who receive the flu vaccine have a 78% decreased risk of death attributable to any cause and an 87% decreased risk of hospitalization for acute respiratory or cardiovascular disease. Those with diabetes who receive the flu vaccine experience a 50% decrease in complications, hospitalizations, and death. COPD patients who received the flu experienced 76% effectiveness against flu-related respiratory disease compared with patients with COPD who did not receive the vaccine. Flu vaccine is comparable to statins and smoking cessation against major cardiac events for adults with heart disease, and may offer more protection against major cardiac events than antihypertensives. When we look at pneumococcal disease, it's important to realize what type of burden it has on the adult population. There are more than 30,000 cases each year, with more than 3,000 deaths. Of these, 89% of cases and almost all deaths occur among adults. Those at increased risk for pneumococcal disease include adults aged 65 years and older, those aged 19 to 64 years with these underlying conditions, including those with an immunocompromised state who are at higher risk, including asplenia, cochlear implants or cerebrospinal fluid leak, chronic illnesses including heart, liver, kidney or lung disease, diabetes, alcoholism, and cigarette smoking. I'll now spend a couple slides on the recommended adult vaccines. Table 1 of the ACIP schedule lists vaccines recommended for adults down the left column, as recommended for specific age groups highlighted in the horizontal header. 6 vaccines are routinely recommended for adults, but many others are recommended on the basis of risk indications. The color yellow indicates a routine recommendation for all adults in the given age group. The color purple indicates a risk-based recommendation, a full recommendation if the patient has a risk factor for the vaccine-preventable disease. The color blue indicates a recommendation based on shared clinical decision-making, and the color gray indicates no CDC recommendation for that vaccine. The schedule is voted on by ACIP in October and then vetted through the American College of Physicians, the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists, and the American College of Nurse Midwives. I'd like to highlight a couple of changes to Table 1. Pneumococcal conjugate or PCV13 vaccine is recommended on the basis of certain risk factors for all adults, but for certain adults older than 65 years of age who may lack these risk factors, shared clinical decision-making should be used to decide whether to vaccinate. Adults aged 65 years or older should receive PPSV23. Similar to PCV13, shared clinical decision-making is recommended for adolescents 19 through 23 years of age for meningococcal vaccine and for adults 27 to 45 years of age for HPV vaccine. We receive many questions based on shared clinical decision-making. I refer many of these questions to this web page, and the URL is at the bottom of the slide. These are FAQs, or frequently asked questions, to help providers attain a basic understanding of what shared clinical decision-making is. At its most fundamental level, this implies a discussion between the provider and patient about the risks and benefits of vaccination in the context of the individual patient. I'd like to update you on vaccination recommendations during the COVID pandemic related to adult vaccination. As different areas of the country reopen and re-expand certain medical services, including vaccination, CDC has provided a framework for healthcare systems providing non-COVID-19 clinical care during the COVID-19 pandemic and considers the potential for patient harm if certain services are deferred and considers the level of community transmission of SARS-CoV-2, the virus that causes COVID-19. More recently, CDC has provided FAQs for healthcare infection prevention and control for COVID-19. For this audience, the most relevant information pertains to personal protective equipment, or PPE, for healthcare personnel providing care for patients not suspected to have COVID-19. It states, the potential for asymptomatic SARS-CoV-2 transmission underscores the importance of applying prevention practices to all patients, and this includes social distancing, hand hygiene, surface decontamination, and having patients wear a cloth face covering or face mask while in a healthcare facility. To protect patients and coworkers, healthcare personnel should wear face masks at all times when they're in the facility. Use of a face mask instead of a cloth face covering is recommended for healthcare personnel because a face mask offers both source control to prevent infection to others and protection from exposure to splashes and sprays of infectious material. Healthcare providers working in facilities located in areas with moderate to substantial community transmission are more likely to encounter asymptomatic patients with COVID-19. COVID-19 is not suspected in a patient, healthcare providers should follow standard precautions and transmission-based precautions if required, based on the suspected diagnosis of the patient. They should also wear eye protection in addition to their face mask, N95s or higher level respirators instead of a face mask for aerosol generating procedures and certain surgical procedures. And respirators with exhalation valves are not recommended for source control and shouldn't be used during surgical procedures, as the exhaled breath that comes through the valve would compromise the sterile field. For healthcare providers working in areas with minimal to no community transmission, universal eye protection is optional. Finally, I'm going to highlight some great resources for you that we have available. As you see here, we have a bunch of links to different websites related to immunization. CDC's patient education portal link is listed here, where you can find posters and flyers, educational fact sheets, MAT articles, web features, radio PSAs, web buttons, and banners. There's a vaccine quiz for patients to take, which I'll show in a few slides, and also the CDC website for adult vaccines is listed here. And if you haven't used the adult vaccine app, this is great when you have questions about the schedule, and these are updated when there are new recommendations. Here's the adult vaccine assessment tool for vaccine quiz. You can enter your age, health conditions, job, and other factors and see what vaccines are recommended for you. Our series of How I Recommend videos feature a variety of healthcare professionals walking through how they make a strong vaccine recommendation to a variety of patients. Some of these recommendations focus on talking vaccine decisions through with adults who have chronic conditions. The Medscape module highlighted here goes through some vaccines for certain patient populations and can be helpful in learning how to give a strong recommendation as well. Finally, there are patient resources for certain conditions, including diabetes, COPD, asthma, and heart disease. Thank you again for your time and attention and for having me today. I'll turn it over now to Dr. Coles.
Hi, thank you very much. I'm very excited to be here to talk to you today about vaccinating adults with chronic conditions, some recommendations and lessons learned from my experience as a family physician. To start with some disclosures, I do participate on the ACIP Influenza and Child and Adolescent Schedule work groups, as well as with the American Academy of Family Physicians Commission on Health of the Public and Science, but I do not receive any financial compensation for these activities. So let's start with a case to think about vaccinating adults with chronic conditions. So M is your patient, and M is a 59-year-old individual who identifies as male, who has insulin-dependent diabetes, heart failure with preserved ejection fraction, and fatty liver disease. And he presents to your office for routine chronic disease follow-up. He hasn't had any recent wellness examination, And when you ask about when he last had vaccines, he says, I don't know, maybe in the 90s. So you review the adult vaccination schedule, considering both his age as well as his chronic diseases, and you identify that he needs a whole bunch of vaccines, including influenza, Tdap or TD, MMR, shingles, pneumococcal, hepatitis A, and hepatitis B. So we know that there are a lot of challenges faced to administering vaccines to adults with chronic conditions, both from the patient perspective as well as the clinician perspective. For patients, they might have poor access to either the healthcare system or immunization services, and this is where the social determinants of health and equity play a big role. Health literacy might be playing a role, as well as vaccine misconceptions and attitudes about vaccination. Individuals might have difficulty navigating the healthcare system because sometimes it can be quite complicated. Cost might also play a role, as not all vaccines are covered under all conditions and insurance statuses. The biggest role, of course, is the lack of a clear, strong recommendation from their clinicians, and sometimes just straight up being afraid of needles plays a part in this as well. For clinicians, there are also significant barriers or challenges to vaccinating adults with chronic conditions. A big one is limited time for preventive care. One study estimated that for a family physician to provide all of the recommended acute, preventive, and chronic care for an average-sized panel, it would take about 22 hours a day to achieve all of those things. So there's lots of competing priorities and only so much time in a day. Cost and storage of vaccines, as well as reimbursement for vaccination services, can play a role, as well as clinician knowledge and attitude about vaccines. For example, only about 1/3 to 1/2 of healthcare workers themselves are immunized against influenza, and that might play a role in the recommendation they're providing. The use of the electronic health record may help or hurt you, depending on what you're using and how functional it is for vaccination status. And clinicians might not be aware of the vaccination status of the patients that they are seeing. Of course, like many things, there are significant disparities that we need to consider when we're looking at vaccines for adults with chronic conditions. With very few exceptions, individuals who identify as Black, Hispanic, and Asian have lower vaccination rates than white individuals for routinely recommended vaccines, and this often holds true in the setting of chronic conditions as well. Vaccination coverage is lower for those without health insurance, and for those who do have health insurance, it's lower for those who have public health insurance rather than private health insurance. Vaccination coverage is also lower for individuals who live in rural communities and for individuals living below the poverty line. So let's take pneumococcal vaccination and diabetes as an example. All told, we've vaccinated about half of our patients with diabetes with the pneumococcal vaccine, so not great. In general, you're more likely to get this vaccine if you're over the age of 75, and I think it's because clinicians think of this as a vaccine for the elderly, and far less likely to get it if you're younger. You're also far less likely to get this vaccination if you identify as Hispanic, non-Hispanic Black, or non-Hispanic Asian, and far less likely if you are living below the poverty line. We have a slightly different pattern for hepatitis B vaccination in diabetes. We don't do nearly as well in hepatitis B vaccination. All told, vaccinate about 17% of individuals with diabetes. In this population, we're much more likely to give it to younger folk than older folk, and there's still a disparity based on poverty. So I don't mean this to be all doom and gloom, and there are a lot of really difficult things out there, but there are strategies that we can do to improve our vaccination rates. The first and most important one is that we need to give strong recommendations at every visit, every time, for every patient. You want your strong, favorable recommendation to be coming from the entire clinical care team, because we want to have a consistent message that this is safe and effective. We want to make sure as we're giving that strong recommendation that we're using a presumptive approach rather than a participatory approach. For example, a presumptive approach would say, you're due for your vaccines today. And a participatory approach would be, would you like some shots? And of course, more people are going to take the first answer rather than the second. We also want to be persistent. Not everybody is going to accept our vaccination recommendation the first time we offer, and that's okay. Many people, upon repeat offering, will ultimately accept the vaccine. We, of course, want to address concerns. So if you experience hesitancy, you want to be curious and interested in the patient's concerns, and then address those concerns head on. So back to our case. You give M a strong recommendation for vaccines, but M hesitates. So that's okay. The first thing you want to do is play it cool. When you have somebody who is expressing some vaccine hesitancy, you don't want to anticipate pushback or disagreement and go into it with kind of this confrontational attitude. More importantly, you want to seek to understand their concerns before pressing your point. Many people just need reassurance or additional information in order to accept your vaccine recommendation. So find out what their concerns are and then address those head on. Be aware of and recognize any misinformation that's out there in the community. There's a lot of it, and your community might have a specific myth or rumor going around, and you want to be able to answer those questions. Many people have very specific safety concerns, so be ready to answer those questions, and if you don't know, be ready to find out. Ultimately, you want to provide accurate education and resources, focusing your education on disease risks and vaccine safety. And if that individual is still hesitant after your conversation, that's okay. You don't want to shut the door on them. This is something that we can readdress over time and time again. It's our privilege in healthcare to earn our patients' trust. And so we need to be available and listening to them in order to earn that trust and have them ultimately accept, hopefully, our recommendation for vaccines. I recommend against dismissing patients for not vaccinating because you lose that opportunity to build that trust. And I encourage you to invite questions and discussion for your patients and make it a real discussion so that they feel safe in the care that they're being provided. Of course, all of this is done in the context of shared decision-making. A basic framework for shared decision-making is that you would identify options, including risks, benefits, and cost. After you've identified all of those things with your patient, you want to check for understanding, and we'll talk about some ways to do that in a moment. And you want to listen to the patient's perspective. Why do they feel the way they feel? What are they concerned about? What are they ultimately hoping to achieve? You want to know what the psychosocial context is around their decision-making and what goals do they have. And then together you can develop a strategy to meet those goals, which very often includes vaccination. Some best practices for shared decision-making include being non-judgmental and listening actively, focusing on the patient. So this conversation is not a great time to be typing or doing something else or looking other things up. You want to empathize with the patient. So name, understand, and recognize whatever emotions they might be feeling. Summarize what they said to you so that they know that they were heard and that you have a clear understanding of what they were trying to say. And use those good nonverbal cues like eye contact, facial expressions, and open posture to communicate clearly to your patient that you're listening and a part of this conversation. Always when we're having these discussions, we want to utilize health literacy best practices, where we write and speak at below an 8th grade reading level, which sometimes can be really challenging to do. To check for understanding, you can utilize the teach-back technique, asking the patient in their own words to explain to you what they understood and what they feel like the next steps are. And if there is a misunderstanding or a knowledge gap, putting the onus of that responsibility back on yourself rather than on the individual you're talking to. Saying things like, I'm sorry I wasn't clear. It was apparent that I miscommunicated this. I think I said this in a confusing way. Let's start again. I also particularly like the Ask Me 3, which came out of the National Patient Safety Foundation. And that's where you want patients to both ask you and to be able to answer for themselves. What is the problem? What do I need to do? And why is it important to do this? And often if they can ask and answer those 3 questions, they'll have a pretty clear understanding of what's going on and next steps. And then we always want to avoid technical jargon, because if you're anything like me, it's easy to slip into jargon. We want to just talk like normal people. Ultimately, when we're looking at vaccines for chronic conditions in adults, we just want to make it easy for our patients to get those vaccines. There are a couple of ways we can do this, and one is to just increase access. Open access scheduling is an option for a lot of healthcare clinics and healthcare services, and that's where you have much of your day open for same-day scheduling and only have limited amounts of pre-scheduled appointments. This, we know, increases continuity, improves patient and physician satisfaction, decreases care gaps, and improves outcomes for patients. Also consider extended hours. Not everybody is available in those 9 to 5 hours. So early morning, evenings, and weekend hours can help improve your vaccination rates. And then consider some alternative options for patients like home visits or group visits. Group diabetes visits, where the day's plan is to do pneumococcal and hepatitis B vaccine, can be very effective. Ideally, you have a stock on site of commonly administered vaccines. You are much more likely to give and recommend vaccines that are available to you and that you're familiar with. It turns out that just providing reminders actually helps as well. So calls, letters, leaflets, and postcards can help improve vaccination rates. But the most important thing is that you review and give a strong recommendation to vaccines every patient, every visit, every time. So back to our case with M, you engage in shared decision-making and M agrees to vaccination, so you're super excited. Visit goes well. When you go home later to do your charting, you notice that M managed to leave your office without receiving hepatitis A and hepatitis B vaccines, which I have for sure done in my practice. So not only do we want to make it easy for our patients to accept and get vaccines, we need to make it easy for our care teams to provide those vaccines. And there's a few different ways we can do this. One is through clinician incentives, clinician education, technology, standing orders, and team-based care. So it turns out that simple strategies to incentivize clinicians to vaccinate are really effective. So just reminding us to vaccinate actually works. So if you're thinking about it, you're much more likely to do it. It also turns out that we're a competitive bunch, and that if you post posters in clinics presenting vaccination rates and encouraging competition between doctors, that works. Providing chart reviews and benchmarking to rates achieved by the kind of top 10% of physicians or the top vaccinators in your office also works. It's another way to kind of implement that competitive drive. Everybody likes those green check boxes, right? Instead of red check boxes where you did something not awesome. It's also really important to recognize that clinician knowledge may vary widely. Clinicians may lack knowledge in vaccine-preventable illness. It's really hard to remember stuff about a disease you haven't seen. We need to know about indications, administration, side effects, and safety of the vaccines we're recommending, as well as storage and handling for those vaccines. Many patients ask questions about vaccine development and the approval and evaluation process of vaccines, so it's really important to be familiar with that and having an answer for those patients, because that's where some fears sometimes lie. We need to know about adverse events reporting because, like all things, there are sometimes adverse events, and we need to be honest with our patients and know how to report that when that happens. And of course, we need to be familiar with billing, coding, and documentation to get appropriate reimbursement for the vaccinations that you are administering, as well as the laws and regulations in your community. And we get it, it's tough. About a quarter of physicians believe that recommendations for adults are difficult to follow, so more education is key. Standing orders are another very effective means to improve vaccination rates. A standing order is a written protocol that authorizes designated members of the team to complete the clinical task without obtaining physician order first. So this is huge. It spreads out the workload and gets a lot more members of the team engaged in vaccination programs. To implement a standing order, you first need to get the support of the entire clinical and administrative team that would be participating in that order. It can't just be one person's good idea. Everybody who's involved needs to have a say and make sure that they're all in agreement for how that standing order should be implemented. You want to carefully choose that targeted order. It should maximize benefit and decrease harm. And you want to have a champion, somebody who is going to make sure that this works, get the team members on board, be there if there are questions and concerns. Once you have those in place, you can actually write the standing order, and that needs to be particularly specific. Identify who is responsible for the task, which patient group it applies to, what contraindications might be, and specific information including dose and route of administration. Then you can actually implement the order and reassess and update the order as needed. Sometimes vaccination recommendations change, or your process might not work as well, and you need to make sure that it's working and that there's not a way to tweak it to improve. Ultimately, of course, this is all team-based care. This is not an individual sport. This is a team sport for sure. So your entire team should be trained on vaccine fundamentals and giving strong recommendations. Everyone on your team should be an excellent communicator that vaccines are safe, necessary, and effective. We want to give consistent messages to our communities and populations. One idea would be to use a population health team, and this can be a group of care managers, nursing staff, or medical assistants who work with registries that identify target populations and care gaps, such as missing vaccines. Often you can develop this registry through your electronic health record or through the state immunization information system. And this would allow you to track and follow up patients who might have a care gap in place. In my office, I'm very, very fortunate to have 3 population health medical assistants who help us manage our target populations and our registries, including vaccinations and chronic conditions like diabetes. They meet with each clinician that they're working with for their patient panel at least once a month for about an hour to review that person's panel of patients and where the care gaps lie, and to identify where are the barriers, who is missing the needed vaccine, and what strategies can we work together on to try to get that patient the care that they need. It really is fantastic, and I can say for sure that it has improved our vaccination rates as well as other metrics for chronic diseases. Another option would be an office champion model. This champion would be somebody who is your vaccine go-to person, and that person would help identify barriers to vaccination and then develop workflows to address those barriers, provide training to others, and really create that shared mission to build a culture of vaccination in your setting. This is your go-to person for questions and concerns. And again, this can be a number of different healthcare professionals who would take on that role. In our office, we have an office champion for vaccines as well as for social determinants of health screening. It's been a really great opportunity to provide some leadership and advancement opportunities for members of our staff and clinical workforce, as well as to build that shared culture around some of these goals. Hopefully, of course, you're utilizing technology to leverage your vaccination rate improvement. And your electronic health record, many of them can be set up for reminders and prompts, some with disease-specific algorithms, like somebody who has identified liver disease or diabetes. This does rely on us to actually code our diagnoses appropriately, which unfortunately we're not always great at, so we need to make sure that we're being careful to identify who has these chronic conditions so that we know who needs those vaccines. I would also encourage everyone to participate in the state immunization information system. And ideally, it would be EHR compatible, but many are not. Unfortunately, there is no national immunization information system, and we know that it is not as widely used for adults as it is for children. One estimate I read suggested that only about a third of clinicians report to the IIS for their adult patients. And always you want to engage your community. Make sure that your messaging is culturally sensitive, is tailored to the population that you are serving, and that you're utilizing the preferred language of your population. Work with your partner organizations and respected community leaders to gain community support, build important and key messaging to help have that kind of trusted voice as well. And then consider having a patient advisory council. So a group of individuals from your patient population or community that can provide you strategies about what you can do to improve both your messaging and services. We have a patient advisory council, and I can say that they have given us a lot of really wonderful ideas, truly that we had never thought of on our own, and has been practice changing for us. Our goal is to reduce missed opportunities and improve rates. And this is where those fun PDSA cycles that everybody loves comes into play. So you want to plan, identify what you want to fix, what is the issue, and how might you do that. Actually do it, carry out the plan, try it in a smaller group and see what works. Study it, so collect that data and see if it had the impact that you wanted or what issues might have arisen in the process. And then act on it. Should that be implemented for a larger group? Does it need to be tweaked? Or did it not work at all and we need to scratch it and start with something new? And then you keep going over and over and over again through these PDSA cycles, because we always have room to improve. So back to our case again, your population health team reaches out to M to arrange the vaccination, and M is going to make an appointment with you. All of this until, of course, a global pandemic happens and everything changes on very suddenly. So COVID-19 certainly derailed a lot of our clinical preventive services. Wellness visits were postponed and telemedicine prioritized over face-to-face encounters when possible. It doesn't mean that vaccination is not important. We still want to be vaccinating even in the era of COVID-19. So consider vaccination when an in-person visit must be scheduled for another reason. If you have them there, this is a great opportunity to vaccinate. Or there's a compelling need for an in-person visit, or the potential for the benefit of that vaccine outweighs the risk of the in-person visit for COVID-19. And then when you're unable to vaccinate for whatever reason, keep track of who those individuals are and then readdress once it's safe again. Here are some references for you that might be helpful. And thank you so much for allowing me to present with you today. I really appreciate it, and I look forward to hearing any questions.
Fantastic. Thank you, Dr. Coles, and thank you, Dr. Jatlawi, for those excellent presentations. We do have some time now for Q&A, and we have several questions, so we'll just dive right in. I've been looking at the questions, so we have a number of them related to COVID-19. So maybe I'll start with one for you, Dr. Jatlawi. Can you say a little more, clarify again the recommendations for personal protective equipment or PPE during vaccination visits related to community spread of COVID-19?
Sure, I'm happy to. So current recommendations include for PPE recommendations for healthcare providers taking care of patients not suspected of having COVID-19. And so with that in mind, but still mindful of asymptomatic transmission, recommendations include eye protection when there is moderate to substantial community transmission of COVID-19, because there's going to be a higher or increased likelihood of encountering asymptomatic COVID-19 patients. In areas where there's minimal to none of transmission, universal eye protection is considered optional unless, a part of some other standard precautions like for surgery or other procedures. The other recommendations that we're working on are forthcoming. So we're working on specific recommendations for vaccination, and we'll include some PPE considerations, and then discussion of routine vaccinations for adults, children, pregnant women, and then some influenza considerations as well.
Great, thank you. And Dr. Coles, you mentioned weighing sort of the benefits and the risks in terms of thinking about vaccination during the current pandemic. Can you give some examples of when the benefits may outweigh the risks for vaccinating adults with chronic conditions during COVID-19?
Sure. And of course, every time it's going to be an individual decision, looking at the risks of the patient who's kind of working with you or sitting in front of you at that moment. One example that comes to mind is the influenza vaccine during flu season for an individual who has a high-risk medical condition like diabetes, COPD, or heart disease. Certainly, it would be arguable that the risk of not getting the influenza vaccine would be problematic. Another example I had was Phoenix. I live in Phoenix. Recently had a hepatitis A outbreak in our homeless population. And I would consider a hepatitis A vaccine in the situation for a homeless individual to be critical, particularly if they have other complicating conditions like liver disease, HIV, or substance use disorder. So you want to know kind of what the community transmission risk is for some of these other diseases that are out there, as well as what complicating or comorbid conditions your patients might have that would put them at higher risk if they were to contract a vaccine-preventable illness.
Fantastic, thank you. And then perhaps moving to sort of a specific question, Dr. Jatlawi, we have a question about the shingles series of vaccines. So for an adult who began the shingles series pre-COVID-19 and is now overdue for their second vaccine, will it be adequate to get just a second vaccine when the pharmacy or wherever they get their vaccines begins vaccinating again, or will that person need a third vaccination?
Yes, thanks for bringing this up. This is a great question and one that we've gotten more commonly. So the second dose can be administered as soon as possible when it can be safely given, and the vaccine series does not have to be restarted, so they won't need a third dose.
Excellent, very helpful. Okay, and then Dr. Coles, you also alluded to the changes with the pandemic and sort of moving more services to telehealth. Can you say a little more about how you are addressing vaccinations and telehealth?
Yeah, absolutely. It's definitely harder, right, with telehealth than it is when you have somebody in person. But when I'm conducting a telehealth visit, even though I'm not able to administer the vaccine at that time, I still bring it up for discussion and provide that strong recommendation. I want them to hear that kind of consistent message. And I let the patient know that once it's safer for them to come to the office, we'll give the vaccine. I also keep a running list of patients who are due for vaccines, and when safe, we have our population health team reach out to the patient and schedule a vaccination appointment.
Great, thank you. And finally, I think we have one additional question here for you that maybe gets away a little bit from COVID-19, but speaks to pharmacists and what pharmacies can do. And the question is, do pharmacists help increase immunization rates, and are there any efforts to collaborate with community pharmacies?
Yeah, I love that question. The answer is absolutely yes. Pharmacists are key players in the goal for all of us to increase immunization rates. Having increased access to vaccines in a variety of settings, including pharmacies, medical offices, hospitals, schools, and workplaces, increase vaccination rates. There are certainly collaboration efforts out there, particularly if you're in an ambulatory care site and you're unable to stock common vaccines. Having that relationship with your local pharmacy, I think, is very important, somewhere that's trusted to refer patients and vaccines. Hopefully, you would have a collaborative agreement in place with that facility to facilitate communication between the pharmacy and your office or whatever site you're at, so you can share information about vaccine status and needs as well as any concerns. We're very lucky to have several clinical pharmacists on our staff that work with us to help us build some of these relationships with our community pharmacy colleagues, as well as to help us build our own vaccination programs. So as much collaboration between lots of different healthcare professionals as we can is far more effective than any one of us trying to do it by ourselves.
That's wonderful. I always love hearing collaboration. One of my favorites. But I do also want to be conscious of time and thank you both for joining us for this webinar. And we hope it was a very informative webinar. We hope everyone enjoyed it. We have recorded the webinar, and an archive will be available soon on the Public Health Foundation's website. You'll be able to access that archive from www.phf.org/immunization, as you can see on the screen right now, once it is posted. And in addition, from that webpage, you can also access the slides from today's webinar, as well as the archives of other previous immunization webinars. So with that, I would just like to thank everyone once again. I really appreciate the presentations today, and I hope you all have a great rest of your day. Thank you.